metabolic bone disease, but I was making rounds with the endocrine fellows at the medical school I'm affiliated, came across a paper last year which discussed the use of a proton pump inhibitor in type 2 diabetics and discovered over 12 weeks a significant improvement in their A1C level. So I emailed Risa and I said, what do you think about this? In the typical Risa style, she sent me over 100 papers to review. So then she came up with the idea that we're going to talk about in a little bit of combining two agents. So, well, why don't you come to this conference and talk about PPIs? So with the disclaimer about not knowing much about PPIs or islet cell regeneration, and nevertheless, I'm going to talk about both. So this story does not begin with PPIs, but actually begins with gastrin. For those of you who are not in the medical profession, gastrin is a hormone that in the adult is made largely in cells appropriately called G cells that are in the stomach and which stimulate either directly or indirectly through histamine the production of stomach acid and a lot of it. In the fetus, however, it turns out there is a pancreatic source of gastrin, and there's good evidence that that gastrin made in the fetal pancreas actually promotes the growth of islet cells, including the beta cells, which make insulin. And there's also evidence that I'll talk about in a few minutes that the oversecretion, the hypersecretion of gastrin results in the formation of new islets containing new pools of beta cells. This is from, not in people, but in experimental data that I'll refer to very, very briefly. And it appears that this occurs because gastrin facilitates the transformation of pancreatic duct cells, the ducts being the structures that drain the pancreas, into islet cells. So this is a story of gastrin to begin with, and then we're going to get to the topic at hand. So this association between gastrin and insulin was first described by two surgeons named Zollinger and Ellison, who in the 1950s described 9 patients with a terrible disease. These people were dying of intractable ulcer disease, and they died because despite an attempt to remove most of their stomachs through surgery, they had recurrent ulcer disease. These ulcers perforated, they became infected, they died of either hemorrhage or infection called sepsis. But they discovered, and unfortunately 8 of these 9 patients died, they discovered that the beta cells, the cells that make insulin, were, in their terms, large. These were surgeons actually, so they said they were large. They also commented, which is, I thought, interesting when I went back to the original paper, that one of those patients died of what they called hyperinsulinemia. That's interesting because in 1955 you couldn't measure insulin, so it's not clear what they meant by that because they didn't go into greater detail, but there at least was a hint there that there is hyperplasia and hypertrophy of the beta cells, the cells making insulin, and that these patients, this may have been due to gastrin. By the way, Zollinger and Ellison did not know what gastrin was. In fact, they postulated that the hormone that was doing this was glucagon, because they didn't know about gastrin in 1955. But since then, it's been shown that the tumor that Zollinger and Ellison had described in their 8 out of 9 patients who died was actually a gastrin-producing tumor, making this awful amount of stomach acid. And there was a study done a number of years ago in the 1970s where they infused gastrin, that hormone made by that tumor that caused all the stomach acid to be produced, and they showed that the response to insulin in patients given glucose was much better than those patients who were not given the gastrin infusion. So again, a little more support for the idea that there was a connection between the production of gastrin, excess production of gastrin, or the infusion of gastrin, and increased secretion of insulin. As you've already heard, you've seen versions of this slide already. Gastrin, this has been shown in animal models as well as human ductal cells. Gastrin, if those ductal cells are bathed in gastrin, those duct cells that are there anyway will convert to functioning islet cells. This has been done through some number of studies, which I won't go into because of the time factor. Most of what I'm about to tell you in the next 4 minutes has to do with type 2 diabetes, but there was one study that was just completed. In fact, it's so new that it's only available online, it's not in print yet, where they did look at some type 1 diabetics, infused them with gastrin and a growth factor known as epidermal growth factor, or EGF. We won't get into too much detail, where there was a remarkable improvement in their insulin requirement, decreased by 75% just over 12 weeks, and their A1Cs dropped from 6.7 to 4.7%. So these are type 1 diabetics on insulin. The additional data that I'm going to run through rather quickly has to do with type 2 diabetes, and this gets back to that paper that I reviewed that I spoke to Reese about and why I'm here today. But let's first talk about how we can get the gastrin up without having to infuse people with gastrin, because let's face it, that's not very practical.
You may have disconnected the tape.